Welcome, everyone. I am thrilled to be here, and I'm thrilled to see you all here. My name is Cara Carter. I know many faces in this room, but not all of you. I am the Senior Vice President for Strategy and Programs at the California Healthcare Foundation, and we are thrilled to gather everybody here to talk about this topic, which is certainly at the top of my inbox, probably at the top of all of yours, and I think just incredibly important as we look to achieving a healthy California. So many of you know us. For those of you who don't, the California Healthcare Foundation is an independent, nonprofit philanthropy. We work to improve the healthcare system so that all Californians have the care that they need. Our focus is particularly on making sure the system works for Californians with low incomes and for communities who have traditionally faced the greatest barriers to care. Our headquarters are in Oakland. We have a small office here in Sacramento, and we have a number of colleagues that join us from Southern California. Today's convening is one of a regular series of briefings that we see many of you at. We hold them in person and we hold them virtually. We sponsor them for the policy community here in Sacramento. The briefings are designed with two objectives in mind. So the first is to bring you information that is relevant to key healthcare trends and issues. And the second is to foster dialogue on potential solutions to the challenges that face our state. In addition to those of you here in the room, we have over 800 people registered to join us via webinar today. So hello to our friends who are joining us on Zoom. We'll make a video of the briefing available so folks can access it in about a week. I've got a couple of housekeeping items that I'm obliged to cover and share briefly. So first, as I said, this session is being recorded. The recording will be available on the CHCF website next week. You'll receive an email with a link once it's available. Second, we will have a Q&A at the end of the session. I'm very much looking forward to it. For those of you who are here joining us in person, I have some colleagues that will have roving mics to come in and ask your questions. And for those of you who are participating on Zoom, please feel free to submit a question at any time using the Zoom Q&A link. Please use the chat function only for technical issues. We have captioning in English and in Spanish for those of you who are joining us remotely. Please check the Zoom chat for instructions on how to access. Okay, on to the fun part. One of the greatest privileges of the job that I do is that I get to have the opportunity to roam around the state and speak with healthcare leaders about the things that are on their mind. And over the past year, in almost every conversation I've had in every part of the state with all sorts of leaders, the topic of AI has risen to the top. Why is that? Good reasons. The implications for AI and in the rest of our lives are massive. I'm in a solid generation where this is the first big technical transformation that I have not been native to and that I'm acutely aware will drive enormous change in my lifetime and beyond. The implications in healthcare, I think, are unparalleled. So the potential to transform healthcare to benefit all of us, I think, is very real and a very big deal. In November of 2022, ChatGPT launched. And if you were like me, you sat at home and you heard about this new chatbot that would allow you to interact with AI, and you watched the videos and you saw the cool things that it could do, and you saw people having conversations with an artificial intelligence that very much mirrored the conversations we have with each other. And you felt some combination of amazement or fear or both, all of those things. But I think you knew at that time that this was different. And this was while building on the decades of machine learning and algorithmic decision-making that we've had in our field. This felt like a different moment. Now, as we sit here in 2024, new headlines hit our inboxes every single month. So as researchers and the industry are racing to understand the potential of these tools and to figure out how to use them, how to implement them, and how to drive change with them, to me it seems like every week there's a new study, a new announcement about AI in healthcare, and often they've focused on supports for primary care providers. Research is already showing how AI can help doctors do a lot of things. So sift through reams of data that would be almost impossible for a human to process to better diagnose sepsis, glaucoma, other diseases much faster and much more accurately than we thought possible. It can help make it easier to update electronic medical records in real time, Had many conversations just over lunch now about the opportunity to reduce pajama time, to increase the space that providers have to spend time with their patients and with their families, to reduce burnout, to increase satisfaction. Just this month, Covered California announced that they were expanding the use of AI to simplify the insurance enrollment process for Californians. So these are all examples of many ways, just few examples of the many that we've seen that AI can lead to better outcomes, improvements in diagnostics, new treatments, innovative clinical supports, and mostly by addressing the wide range of administrative and back office pain points that affect payers, providers, patients, really all of us. We all wrestle with this stuff every day and every time we interact with the health system. So these examples, to me, speak to the promise of AI to help us solve everyday problems in the healthcare safety net and beyond. That said, I want to be clear, AI does carry risk, and the risk is real. So we know that algorithms have been shown to perpetuate bias and inequity. We know that implementation of AI raises concerns over data privacy, over responsible oversight, and most of all, inequitable access to the proposed benefits that it could bring. So in my mind, all of this speaks to a strong need for policymakers to provide leadership, to make sure that AI is responsibly deployed, that it benefits all of our communities, not just the wealthiest ones, that it is supporting and augmenting, not replacing, our workforce, and that it's helping to build, rather than erode, trust in the healthcare system. When it comes to AI in healthcare, and in fact AI in all walks of life, we are very much at the beginning of a conversation. We're just starting. We're just getting to understand. And that's why conversations like this one are so important as an opportunity for us to learn from each other. So to get us started, I want to introduce our keynote speaker, Secretary Mark Ghaly of the California Health and Human Services Agency. Secretary Ghaly is at the forefront of healthcare and social services in California, leading initiatives that impact the lives of millions across our state. We know how super busy he is, and we're very grateful to have him with us today to share his thoughts on AI and the safety net and talk about the challenges and opportunities that lie ahead. So please join me in extending a warm welcome to Secretary Mark Ghaly.
Okay, good afternoon. Officially, it is afternoon. Really, Cara, thank you. Sandra, somewhere, thank you for including me in this convening. Really excited to be here. I think we have, within Health and Human Services, been thinking quite a bit for many, many months, can't say years, but many, many months, about the potential impact of AI and Gen AI as well, and in particular as a tool in the safety net. And if you hear anything today from me, it's how does the safety net not run away, afraid of the obvious risks and concerns, but that we stand tall and strong and look at the opportunity in front of us. And that, you'll see, doesn't come lightly, but it does mean that we behave differently than we typically do around innovation and technology. So can AI help, Cara, you asked this, free up our time to do certain tasks that enable us to spend more time with patients and people that we're there to serve? I think the answer loosely is probably yes in some ways, but at what cost and what expense? And will that in any way actually affect the primary reason the safety net is around, which is to address health disparities, to provide service and care to those who may not otherwise receive it in that high quality, equity anchored way? And so this is, I think, the balance that we have to figure out. It is no doubt that technology is often slow to be adopted in the safety net. I know it's been, frankly, decades long just getting all of our safety net providers on an EHR. Still in some places, we don't have that. Just in the last year or two, we've been giving clinic transformation grants out to help support small Medicaid practices to get on an EHR. Big systems, commercial systems have been on an EHR a long time. Why is that the case? Sure, cost is driven, but often safety net providers are among the last to say, stand up and say, we need this technology for our patients, for our communities. And I think with AI, it is our hope that that isn't repeated. So, it goes without saying that there is a unique response or opportunity for the safety net in AI, and my hope is that today's conversation spurs that among our panelists, who I know are going to share their views and experiences with AI in their own systems, but also among all of you, what are those opportunities? And if there is a way, some of my team and staff are here, I know many are online, the sort of door is open. We're interested and curious where all of you, our partners across the state, see a tremendous opportunity to really advance AI in the safety net. So, Cara, you mentioned it. I think it is this real balance between the fears and the optimism. I, too, track very regularly, not just in journal articles, but in those emails that come from a small provider who say, hey, we're trying this out in our own sort of neck of the woods, and it's starting to show this. And not just small providers, some of our biggest providers testing out AI, not just machine learning aspects, but also that generative AI to respond to patient needs, to support providers, to help glue together teams. And I think it is a really blossoming piece of work that we can't even keep track of. And to your point, Cara, one of the areas that we have significant fear around is, can government, who's responsible for that safety net with all of you, actually create a regulatory framework that supports and secures equity, quality, access in all the ways we can imagine? I'm sure as you've all sort of been thinking about AI, my friend Maria Lemus is here somewhere. Where is he? Maria, sitting near the door just in case this is that boring. You can take off, I see. But Maria and I have talked for a long time about community health workers and this opportunity in California to really embrace this set of community professionals in a way that we've never done before. Medicaid has created a benefit. We're deep in community talking about what a certification process might look like, what the legislature's asking questions on how to make this benefit more robust. I think there's a real hunger to increase the use of community health workers, promotores, across our state. One would question, and we have certainly in this hypothetical case of Eduardo, who is a community health worker somewhere in California, who, because of these opportunities, now has a broad range of colleagues that are not just working in community health and population health, but actually delivering care on teams. I know my personal experience using community health workers in San Francisco and in Los Angeles really opened my eyes to the opportunity to draw on that community professionalism, but now to equip this group of individuals with tools that maybe help fill gaps, allow them to do more and do different things, allow them to spend a bit more time with their growing panels of people that they're helping support and work with, really becomes a tremendous opportunity to draw the benefit of that individual more broadly than I think we've ever imagined. Dr. Hernandez and I were part of a group just yesterday who adopted California's first ever cost target for healthcare delivery systems. I know lots of people with different opinions, but this idea that we are no longer going to allow healthcare to continue to grow and grow more unaffordable in California, I think requires us to look at tools like AI, other technologies, not with the fear, but with the confidence that together we can imagine ways to use it more effectively. So Eduardo, I think, is an interesting case study and example of where in a workforce where we're just now starting to, at a bigger scale, recognize the value and opportunity to add some of these tools potentially to help Eduardo, colleagues like Eduardo across the state do their job differently, and I would hope a little better. Cara, you mentioned it. I think we in California, so just to rewind a bit, the governor, it's almost been a year, he challenged the cabinet around AI. He said, you know, this is coming, let's not sit idle. He put out an executive order a few months later saying, you know, California wasn't going to sit back and just wait for federal guidance. We were going to work to really lean in on where AI was. I was one of the first secretaries in the cabinet to say, we're interested to see where this might help, not just support health on its own, not just to support human services on their own, but how they might get connected because of these tools. We're in the process of finalizing, fingers crossed, some awards around 2 specific projects that we raised up. My team of directors raised up as areas of need. We put what we call an RFI squared, request for innovative ideas, out on the street around 2 big areas. One is not as exciting as the second, so I'll start with that one, but really important, how we do our surveys of facilities within the California Department of Public Health. As you know, those surveys are really important. They help us make sure that quality and access is strong in all of our facilities. And historically, that isn't always done as consistently, not just in California, but across the country. How do we use a tool like AI to help make that more timely, more consistent, and better, frankly, for patients, providers, facilities, and for the state? We are exploring that for a partnership. The second one is almost an obvious one, but something that we think would really change the face of health and human services in California, which is around translation. We do enough. It is hard enough to get threshold languages done, but how can we potentially not just transform all of our documents, but our websites, our ability to interact, even some of our call center inputs around AI. So I think these are 2 areas that we are just starting to jump into to see what happens next as they relate to uplifting and strengthening the safety net. So here are the core values that we on our team, and thanks to some people in this room who've helped us get there. And you'll see these are familiar to a lot of folks because they're not that different than other entities that have put out core values. But we felt and are wanting to promote these as a set of guiding principles, if you will, values. Addressing inequities, number 1. We see our role, as I started, the safety net has this large responsibility of supporting around disparities and for communities that often go without. We do not want to see AI's adoption in any way affect our ability to close those disparities. Enable service delivery, anchored there. We all dream big about how is this going to change specialty access? Will this help us on our big behavioral health challenges across the state and make more access? We believe it could if we pay attention to, frankly, number 1, promote accountability, and frankly, it should say transparency as well. Protect privacy, Cara mentioned it. I think it's one of the main first red flags that people raise. How are we going to protect privacy in a world of AI, especially generative AI? Generate demonstrated value, of course, that makes sense. Empower human capacity, again, not to replace the human, but how do we support and augment what they as individuals, what the teams that they work on are able to do for our safety net populations, strengthen our communities, cultivate innovation. I always think of, unfortunately, innovation hits the safety net last for so many different reasons. How do we make sure AI doesn't have to hit us first, but that we're in line to make sure we're there for the benefits early, and then improve accessibility. I think some of you probably know just a couple of days ago at Kaiser San Francisco, healthcare workers demonstrated around the implementation and use of technology. That is a strong signal that we need to, as leaders, as policymakers, as people running systems in communities across California, need to open the door to the conversation about how we're using technology, not to threaten jobs, but to strengthen. There's so much work to do here, right? There is so much need across California. It is possible for us to think together and collaboratively around where this goes and what the opportunities are. So when I read that article, I saw immediate, appropriately so, concern and fears, but we need to, as leaders, dig in, open, be at the table, and help guide some of those conversations. So as I wrap up, these are some questions that we think we have an opportunity and must answer. It really, again, many of you heard, change happens at the speed of trust. I think that is going to be here very, very applicable. So how do we work and deliberately build trust and familiarity in communities where safety net providers are today? And this isn't how do you get the MAs and the nurses and the doctors to accept it. It's really how do we work with our patients, families, and communities to see where the advantages are, where the disadvantages are, and begin to address those. How do we help our patients and their families see and understand and learn from and listen around how this can help support their care. I've seen and sat through so many demos now, some of the exciting things that could happen in cancer care, that advanced population care in diabetes or HIV. I mean, these are tremendous tools if we use them responsibly, appropriately, and fully transparent to help augment and support care. I'll just repeat it because I think it's a theme at our agency around connecting dots and making sure that health over here and human services over here get more deeply connected. We see an opportunity here in AI. What does that look like exactly? How does AI expand access? I immediately go to behavioral health. I think that the opportunities there are ripe. The need is huge in California, whether you're talking about young people in the Central Valley or older Californians in Los Angeles. We don't have enough access to the tools in behavioral health. And here's an opportunity for us to think about not how do we replace a workforce at all, but how do we fill this huge gap and divide that is growing by the day. I wrote this next bullet this way because I do think we want to not. We had an interesting conversation at our OCA board meeting yesterday, Office of Healthcare Affordability board meeting yesterday, about continuity and the need, the idea in primary care that continuity is important and critical. But it really is driven by familiarity and relationships. And those relationships with patients and families and communities are important, and we can't afford to have technology begin to replace that in any significant or meaningful way. And then lastly, how do we address this generational gap that likely does exist? Cara, you mentioned it. I think that it is likely that those who are used to adopting technologies like AI are going to be much more excited and familiar to let that sort of guide some of their care, wherein maybe other patients, other families are going to be less interested. So how do we have and set up approaches that recognize that? By way of closing, I would ask all of you, not for a response now, but always welcome to hear it directly or through whatever channels it can get back to us. Or what do you think the opportunities are? Where do you think we should start? Where do you think we shouldn't start? What are some of the key threshold questions that we at the state should begin to entertain and explore how to answer? And I think that uncertainty is real. But I believe that with us working together, with us eager to see what we can unleash with this technology, we can make California not just a leader for leading's sake, but actually improve some of the health and social service outcomes that I know everyone in this room is interested in helping improve. So with that, thank you again for inviting me. And I can't stay for the panel, but I look forward to seeing the video in a week.
offer a huge thank you to Secretary Ghaly before he walks out the room. Really helpful and inspiring presentation, and I think a great tee up to the conversation that we're about to have. So I'd love to invite our panelists up here to join me. Welcome. Thank you for joining us today. I'm going to let you introduce yourselves. So why don't you come on up? We're looking forward to hearing your thoughts and what you have to say. So while you get settled, I'd love to just kick us off with asking you to introduce yourselves, the organizations that you represent, and in kind of, I don't know, 15 words or less, what your organization is doing on AI, and then we'll get into the meat of it, the tofu of it. Susan, you want to get us started?
Hello, can you hear me? Yes. Excellent, wonderful. Hello, everyone. First, I want to say what an honor and a privilege it is to be here on this panel. It is an incredibly important topic, and I really appreciate the Foundation's focus on the safety net and equity. My name is Susan Ehrlich. I am the Chief Executive Officer at Zuckerberg San Francisco General Hospital. I am a professor of medicine on the UCSF faculty, and I am a practicing primary care internist. And so I think all of those roles give me a unique perspective on this topic, and I look forward to sharing some of the work that we've been doing in machine learning and AI at CSFG.
Okay, well, I'm Carolina Reyes, and again, it's a real honor to be here, to be invited to be on this panel. I am chair of the board for California Healthcare Foundation. Our role as a board is really trying to make sure that we provide the framework in the philanthropic work around meeting our mission, providing meaningful, measurable difference in improving healthcare, and especially for low income and those that are marginalized. And so so part of my role is to look at sort of what's the framework that we use as we grant funds to help support the safety net. My other role, I'm a high-risk OB specialist at UC Davis in that practicing role. And so day to day, yes, we see tremendous, excitement about this introduction of AI in helping improve the role that we play as providers to improve care. And then thirdly, I am a trustee with Common Spirit Health, a large health system that has over 144 hospitals in about 8 states. And so again, looking at this from the trustee perspective, what are the principles and values we need? And then what are the kind of support systems that our health systems need?
Dave Lebarski. I'm a professor of anesthesiology and nursing and business at UC Davis. I'm the CEO of the Health Delivery System and the Vice Chancellor overseeing both the School of Medicine and the School of Nursing. And UC Davis is really staked out, I believe, a leading role in the application of digital technology and AI. I've really pushed our organization to find the good and to make sure that the evil doesn't leak in and that it serves the purposes of our entire mission of teaching and research and clinical care especially, and our social mission to push health equity. And there's a lot to be done. I said to my team last year, 2023 was going to be the year of practical implementation of AI. And as 2023 unrolled, it turned out we weren't quite ready for practical implementation. It was the year to prepare for practical implementation because, as we've been talking on the side, it takes a lot of resources and a lot of work to prepare yourselves and your data and your data lake to take advantage of what AI can do. This year, 2024, is the year of practical implementation, and I really believe that we are going to dramatically change patient outcomes in several areas and reintroduce the joy of medicine into the workplace.
Thank you. I actually want to pick up on exactly the two themes that David just landed us with. So first, we'd love to hear from all of you on where you see the biggest opportunities in your institutions, but then in the spirit of practical implementation being hard, I'd like to understand a little bit better what makes it hard and what you've come across so far and what you can see on the future horizon. And maybe we'll start the other way. Why don't you kick us off, David?
Wow. Okay. So, those are big. I think actually Mark got it exactly right. Stephen Covey Jr. wrote the book, The Speed of Trust, and that determines the speed of change. You can't get anywhere unless people actually believe it's a good thing. They will resist and fight, and that's a great thing because every single nurse and every single doctor I know is 100% committed to the safety and the excellent care of their patient. And if we don't bring them along day one with the idea that this is actually a good thing, then we'll fail because they won't believe it, they won't adopt it, they won't act on it. And the idea of AI, dubbed artificial intelligence, is incredibly wrong. It's just augmented intelligence. It's just advanced data analytics being done in a way that we humans can't do, right? We're really good at pattern recognition, but, things like remote patient monitoring, which we're implementing, that's delivering 10,000 vital signs a day for every single patient that we put a remote patient monitor on. I mean, holy cow. If you have a ward, right, and you have 20 people on the ward, and you're getting 10,000 a day, well, that's 200,000 vital signs to look over in a day. Nobody can do that. Only a computer can do that. So understanding how does a computer act as our assistant so that it can draw our attention to what needs to be done. And that occurs not only in remote patient monitoring. We also have AI Doc, which is another company that rank orders the severity of chest x-rays that might be found in our ED so that our radiologists, they're not giving up control to the machine. They are just being directed to look at the one that really has a problem so that gets treated more quickly. And if you treat things in a more timely fashion, you get better care. Our docs have adopted that. Our ED nurses believe in it. And so that's pretty easy. And we're about to roll out something that I'm the most excited about, which is a partnership with Viz.ai, another program that reads neuroradiology scans and will shorten the time from the time people go to a CT scan to evaluate a stroke to the time that life-saving, brain-saving, function-saving thrombectomy, removal of a clot, will occur for our patients. We're already rolled that out at UC Davis, but more importantly, we're about to roll it out at an allied hospital in a different health system that doesn't have someone to do the clot removal. And it will likely cut 40 to 50 minutes off of that patient's transit to us to get that life-saving operation. But also, more importantly, will identify those who shouldn't be transferred. So we'll lower the total cost of care. It will increase the ability of us to save brain tissue. It will leave patients who really could be treated just as well because they're not a candidate for that back in their home hospital near their family. And this is just good. And yes, we have an obligation to set up the right governance, implementation, and post-implementation validity studies to make sure there is no disproportionate or negative impact. But there won't. In this case, we've already tested it on our own, and it's not, and we're pretty sure, but we'll continue to do that. So that's this year, and we haven't talked about Gen AI.
So, but I want to, just as we dive into, before we dive into Gen AI, I'm curious, I get excited by everything that I hear David say, and I guess, Susan, I'm curious, can you talk a little bit how we can make sure that the benefits that David is highlighting and the excitement that he's talking about reaches all of our communities, including our safety net?
Yes. Yes, I would love to do that by telling the story of how we've used AI in the most interesting way, I think, so far at ZSFG. And just to make sure that everybody knows our hospital, Zuckerberg San Francisco General Hospital, we've been in San Francisco as the safety net provider for 150 years. During that same 150 years, we've been in partnership with the University of California, San Francisco, who are all of our providers, plus a lot more on campus. We are the city's safety net. We are the only trauma center in not just level 1, but the only trauma center, period, in San Francisco and northern San Mateo County, which is about 1.5 million service area, 1.5 million people. We're the only 24/7 psychiatric emergency service. So we are a very important and iconic provider in San Francisco. And we're incredibly special. And yes, we're a safety net, and I would say that we are among the most privileged of safety nets for a lot of reasons, because we live in a community that supports us 100%, because we have brilliant UCSF faculty and really dedicated staff and providers who take care of the 100,000 people we take care of every year, just quite brilliantly. And so we're not running away from AI. Quite the contrary. We do what we do. We're doing with AI what we do with everything, which is to look at the problems that we face every day, which are considerable, and we think as creatively as possible about how we address these problems with very limited resources. So I'm going to tell you the story of how we've started to use AI, and this is around clinical care. There are still other possibilities with supporting our providers, supporting our revenue cycle. They're endless. So is AI going to be good or bad for health equity in California? I'm on the cautiously optimistic side, and optimistic because we've seen some incredible results from AI, but cautious because, just like you're saying, it requires a huge amount of resource. It requires expertise, it requires time, and it requires a lot of money. So here's the story. In 2017, 2018, we started to realize that our heart failure readmission rates at our hospital were among the worst of safety nets in California. And this is a big deal because, as many of you know, we have a significant amount of our revenue coming from value-based care, and heart failure readmissions is one of those statistics that we need to be good performers on, and we were not. So we started looking at why this was the case. What was it about our patients or our care? What was going on that made our results so poor? And what we realized was that there were very specific characteristics of the patients who were coming back to the hospital. They tended to be Black African American men. They tended to be men who had substance use disorder, specifically methamphetamines. And they also tended to have other social determinants of health as a factor, chiefly housing instability. So we looked at those things and realized that because they were the root causes of the problem, we had to address those root causes. So we put together small tests of change, which is what we do when we want to test something and see how it works. We created standard processes for diuresing, taking fluids off patients in the hospital. We developed a special interdisciplinary team, the heart team in the clinic, and we established an outpatient clinic, the Heart Plus Clinic, that was designed not just to see patients for their heart failure, but also for their substance use disorder. So all these things worked pretty well, but we needed to take it to scale. And we knew that in order to do that and do it effectively, we needed to be able to identify people when they first walked in the door. So this is where the machine learning came in. We started being able to identify, using the data that we knew was relevant to our patients. This is a very important thing that we're talking about here, to identify those patients early so we could get them enrolled in this course of care. In the process of doing that, we set up a small team who is really focusing efforts on clinical care and AI, machine learning and AI, in conjunction with UCSF. And what we saw, and I can tell you more details about this, but what we were able to do over the course of a few years by using machine learning, identifying patients in the hospital and at the population level, we not only went from being the worst performer to the best performer in heart failure readmissions in the scope of a few years, but we reversed the disparity we saw. So Black African American men actually did better than the general population. So that gave us a lot of encouragement that this is going to work well, right? The things that I mentioned before, expertise, time, and money, really come into play here. Even though we are in partnership with UCSF, who gives us access to the data lake, it's got to be our data. It's got to be our patients. That data needs to be transferred to the lake. We need to do machine learning with experts on that, and then it needs to come back into our records so we can use it to do the prescriptive care. This is a big lift. It's a big lift. And we're doing it, and we're watching our colleagues at UCSF move far ahead of us in their ability to take advantage of these technologies, AI, machine learning, just because they have more resources than we do. So I hope we talk more about this. I want to give others a chance, but I'm very optimistic because we've seen it work, and I'm cautious because of the limitations we have in the safety net.
Thank you. Carolina, I'm wondering if you can share some thoughts on what you're seeing, and also you see both safety net and other institutions in California and in other parts of the country.
I think most importantly is just to add on to what's really been said about this huge lift, I think, in terms of trying to help systems be much more efficient. It's always so critical to keep your eye on that North Star, that we want to treat patients with dignity, right? We want to treat them with quality care and continually improve care. So if AI is not helping us improve care, then it's not useful. I want to talk a little bit about some of the other aspects for why we're excited. It's not just in improving, sort of as a provider, my efficiency in terms of what I can provide that patient, but I really do believe that the patients are going to be much more informed when they come in to see the patient. I think we don't do a good job yet preparing patients to say, write down your conditions. What are the questions you should be asking your physician or your provider when you come in? And what are the types of things that you need to have in place before you leave that visit, right? And so I do believe that patients can ask that question and to say, what are the questions I need to be asking so that they're well informed? And I also believe that that interaction with the patient and the provider is going to be more focused on the caring of that whole person, right? It's not just that individual, issue. Okay, your blood pressure is high. Let's treat your blood pressure. But it's really about having the provider having the full data around that one individual patient, because each patient is really unique. So it's how do you incorporate the data, knowing where that patient lives, what their situation is like, and their health condition, and to know what has worked and what hasn't worked for that patient. And so I do believe that it's going to improve that patient-physician interaction significantly. And then the follow-up. I do believe that we're going to be able to have much better follow-up with our patients without question. So I do think patients are going to be well more informed. On the population health side, I do believe that, we're always a little late in including population health studies and data so that it informs where our patients live. And again, this is helping bring things in real time, right? Population health data to help inform that patient interaction and certainly our policy priorities around that. I do want to say, though, in terms of the hard work to make this work, the systems, large systems that have interoperability, sort of a complex interoperability system, need to make sure that those systems are secure. And not just within our individual system, but really with our vendors, that they are following those same core values, those same core principles, and that they have certainly their level of security and reliability of their data that we're using. But bottom line, I do think it's so important not to be afraid of this. I do think that it is here to stay, and it's going to revolutionize what we do. We do need some guardrails, as Mark was saying, but I do think that it's going to help us be much better at our interactions and help us be treating patients a little bit more humane, I think, with a little bit more dignity.
Thank you so much for bringing the patients into it and the opportunities for the patients. I think about 3 dimensions on the topic broadly that we need to address. One is in our institutions, one is with our patients, and one is with our workforce. So maybe we'll start with the patients since you raised them and community engagement. We know from the CHCF survey this year that more than half of Californians have some skepticism or some concern about AI being deployed in their healthcare. And I'm just curious what thoughts you have on how we can make sure, that we are engaging with our communities to move at the speed of trust, to make sure that people are coming along on the journey with us. Maybe you want to...
Yeah, sure. I mean, I think I think the key is to be absolutely transparent about the safeguards that have been constructed and the principles. They're no different than the principles that doctors bring every day and other administrators bring every day to the workplace. Like, we care about our patients, and that has to come out first and foremost. And this is just another tool. And I'm going to give an example because I want to go back to what both my colleagues were saying. So we created a collaborative. It's the largest voluntary collective of health systems in the U.S. called Valid AI. All the 5 UCs are in it, but it's about 50 large health systems now. And its whole purpose is to share the learning so that everybody doesn't have to reinvent the wheel. And if you have all these people working together and standing up and saying, hey, yes, we looked at this implementation, we evaluated the implementation, here's what we found, here's what we had to do to make sure that it didn't breach any ideas around equity or mistrust or whatever you're thinking about. I think that's going to be really important to have, not just me saying it and not just UC Davis saying it or not just Dignity saying it and not just UC it, but everybody together saying, yeah, this is a good thing and it is working. And then maybe we'll get the trust part. And the second thing is that one of the things that that collective has done with the support of Amazon Web Services, which has been incredibly supportive of the social dimensions, the social determinant of health dimensions, is they've issued a challenge that they're paying for to develop a Gen AI driven social determinant of health bullet point through Epic, just because the data exists all there, but it doesn't exist in structured data fields. Only AI can pull it out of all the notes and the comments, the zip code, and whether or not it is or isn't in a food desert. All that can be done. So they've issued a challenge to all 50 health systems that are in this collective. And then as soon as they get the best product, then they're going to distribute it for free to the United States of America. That's the way it should be. That's how you build trust, because you have all these really smart people working on it, and you make it's not a competitive advantage to take better care of patients, right? That's not the competitive advantage thing. It's a moral imperative, not a competitive advantage. And I think that's how approaching AI as a moral imperative to do better is the right way to go.
I think, to answer your question, the only way to make this work really is, I think we're not only revolutionizing the technology, but I think we're going to be revolutionizing community engagement and what we really mean by involving stakeholders that have a true stake in this. And I believe that some of the work I know Sergio Aguilar-Axiola does, certainly with the CDC, bringing public-private partnerships so that we're all using the same definitions. Certainly those core values that Mark brought up, I would say that any company in AI, as well as a provider, as well as a patient, would agree to those. But the reality is that sometimes those definitions are different, right? For the company that's actually producing safety, their definition was really different than what we would consider safety for a patient and safety in community. And I think this is where community engagement really has to come to the forefront. And we definitely have to revolutionize how we engage so that it is structurally integrated in every step of the way, that data is incorporated, right, as well as data, how it's interpreted. And certainly we need to find the structure so that there's constant reassessment of this new technology and how we're using it and has it provided value. So in many ways, I think we need that skill base, right, that helps us incorporate that engagement component. But I also think that in terms of our workforce, there's a skill base at every single level, from the clerical worker up to the CEO, up to health system and administrative leaders, that we need to incorporate, sort of upskill, our workforce, and that creating mechanisms so that we understand sort of ethics better, that we can look at the data and interpret it and say, have the confidence to say this may not look right, and not just automatically assume that because it is already sort of analyzed through this complex computational design that it's accurate, right? So it's how do we create a workforce so that at every single level we have the cognitive skills, the ethical skills, to be able to use those skills for judgment calls at every single level, and that then the clerical worker has just as much say in saying something's not right and to take it up to make sure that it's incorporated in terms of how we improve the work that we do.
I think we have a really rich conversation on workforce that I definitely want to come back to. But before we do that, I would love to hear, the point that you've made on the different ways that a consumer or a patient or a community member might define safety from how a policymaker or an administrative leader might define it, I think is really intriguing. And Susan, I'm curious what your thoughts are on that.
This is such an important issue, and especially in the safety net, because the issues of trust are paramount. We know that at baseline, forget AI, we have issues with trust with our patient population, and it takes a lot to gain, regain, and to keep that trust. I know that very well as a primary care provider. That is always my first, middle, and last order of business is my relationship with my patient, because I know that my patients, our patients, have so many things in their lives that are difficult and challenging, and they've been failed many, many times. And in order to build that trust, not only do we need to be transparent about what we're doing, including with AI and all the tools that we use with the electronic health record, but we have to be able to deliver things for them. And that's really hard. It's hard to gain trust around AI, which is a very esoteric thing, when somebody is struggling with housing or food security or substance use disorder. In so many ways, those things come first. And so it's a big thing, but at least we have to be very cognizant of communication, of building trust, and of making that paramount in all that we do around AI.
Thank you. Let's hop back to workforce for a minute, because I do think like with all transformations in the health system, they depend on people to do something different, and they also create opportunities for people. So many of my friends know that one of my earliest personal memories was my dad was a dentist and sitting on the couch in the living room when he came home, and then long after I went to bed watching him chart deep into the night. And I'm excited by, both the, Carolina mentioned many of the training obligations that we have, but also the opportunities to really free our provider workforce up. And I'm wondering if maybe you can kick us off just on that.
I guess, there's a lot I think we can say about workforce. It is really fascinating. I don't remember all the data about, how many physicians are you really going to need, how many nurses, et cetera. What are the different types of occupations that you'll need to help as you incorporate AI, as you're making things a little bit more efficient. As David said, AI computational analysis and inputs and outputs really help simply augment what we do. It really doesn't replace what we do, right? You still need that human interaction, that human interpretability in order to provide that quality care. And so, again, the focus on, like I said, if we keep that North Star and just say we want to treat patients with dignity and we want to continue to improve our care, I think that will help us define the kind of workforce that we need. I do believe that we can do a lot better in terms of bringing in a workforce that's representative of community, right? Bringing in a workforce, and not just the individual lower level workforce. I'm talking providers and the rest of us, but really at the leadership level, that it's representative of the populations that are served, so that when those decisions are made, it's not sort of reacting, but we're proactive. And so I think in terms of trying to make sure that there's appropriate representation at many levels, we have a long way to go to achieve that. But I do believe that we need to at least start there. In terms of skill base, like I said, I think there are very specific skills that I think we need as individuals that need to begin not at the college level, but really in primary, secondary, higher education schools. How do we train individuals to think in a way that helps them look at data and be able to question and say, questioning is healthy. How do we do this kind of thing? So I do believe in many respects that's what we need to do.
Thank you. Let's pick up, you mentioned, thinking about what kind of workforce we need. And many of us have sat in this room in other briefings where we've talked about the shortages in health workforce in California, the supply and demand mismatches in terms of geography and race and ethnicity and demographics and specialties. Maybe we can talk a little bit about how AI can help us address some of those challenges. And David, maybe you get us started.
Yeah, sure. Well, first of all, I did want to touch one thing about safety and before we leave it, because this has come up in several news reports lately. Perfection is not what we're seeking with AI, just for the record, because there's still a human being checking it. It's, is there a proportionate benefit from using it versus not using it, right? And so I think that's very important to change the conversation. And it's the same thing with workforce. We're not going to replace primary care doctors because, as Susan said, it's the relationship, right? And I like to use a term called assurance, which is guaranteed you got the right data, the right algorithm, the right output when you want that. And when you want a helping human hand, you get that too. It's not one or the other. It is one and the other. So I think those are important distinctions about how you employ it. And then when you talk about it as regards the workforce, I mean, this is critically important. I know one of my ex-faculty members who's retired, but not really retired because he's working on an asynchronous ability of an AI actor to do a psychiatric intake form and then direct the psychiatrist's attention to the 5 minutes of the interview that they have flagged as, okay, this is going to help you decide if this person needs further help or not. I mean, that's changing the demand for psychiatry. And believe me, there aren't enough psychiatrists and psychologists in the world. So if we could get to asynchronous directed care, right, then we're talking about, well, maybe the workforce is sufficient. I mean, maybe still probably not, but at least we'll do something to move that. Same thing with a cardiologist. Right now, we already know, forget about AI, that if you can just get an e-consult with a primary care doc, 50% of the demand for subspecialty care disappears because they've gotten the answer that they need, and this person doesn't really need to see the specialist. That could easily be automated through AI and through an interactive AI chatbot. And then all of a sudden now you actually have plenty of ability to impact care with fewer subspecialists. And then last but not least, the geography thing, right? Is technology trumps geography. There's not only underserved communities in our inner cities, but tremendously underserved communities all throughout rural California, a region that we serve, especially northern and eastern California. And the ability to actually connect people using AI, where they can quickly scan all the relevant information in the medical record and deliver it and say, does this patient need to come in? Does this patient need a molecular test for their cancer, right? Is this patient a candidate for a potential cancer study that wouldn't be available in their community? All of that is possible and will change the number of people that we need closer to the number of people that we have. And so I think there's just amazing opportunities. And last but not least, the other impact on the workforce is that people leave the workforce. Nurses leave the workforce at a tremendous rate. Doctors retire early. It's not much fun to spend somewhere between 35 and 50% of your time becoming a glorified typist. That can be eliminated with Gen AI. Take the worst drudgery, the lowest value that you can find is typing into a computer and checking off boxes. We can eliminate that, and we didn't mention that. We're evaluating Gen AI solutions to generate notes. It's really critical that we bring back the joy of medicine because then they will be happy to see patients. They'll get better care. They'll stay in the field longer. They'll enjoy their lives more. It's super positive as long as we don't get AI drift and we don't get hallucinations and all those other things. And what's interesting is that there's a company called Pieces. I just happen to know the CEO. We're not using them, but want to look at them. They have something called adversarial AI. So they're doing inpatient note generation, and they've gotten the error rate down to 1 in 100,000 notes because they have AI doing the summary, and they have another AI program running to check for its incorrectness, if you will. And so technology may solve some of those problems. So I'm very excited about that because I believe that we haven't done a good job in making the promise of electronic medical records and digitization help doctors or nurses in any way, shape, or form, not to make them take better care. And we're at the cusp now of being able to totally turn that around, not only make it have better care, but bring back the high value work of personal relationships and insight into the care arena and get rid of becoming a glorified typist.
So I would love to pick up on this topic. We started around workforce, and I think it is really hard to work in healthcare right now. As someone who looks at staff engagement scores from our surveys across the organization, it's not good right now. And it doesn't matter what kind of work you're doing, whether you're a physician or a health worker or an eligibility person, food and nutrition, people are less engaged across our organization. And when you look at what it is that's driving that, a lot of it has to do with the fact that they just don't have the tools to do their job in the way that they want to. And that means a lot of things. But one of the things that we know is that the burden of our electronic health records has just gotten really tough for people. How many people know what pajama time is? Okay, pajama time is when you are charting in the electronic record early in the morning, late at night. I do this a lot. And it's hours of time. And AI has the possibility of taking that away, right? And how is it going to do that? There's a product that we'll be using called ambient notes. And so instead of me sitting there and trying to look at my patient and type at the same time and then typing, before and after, ambient notes listens to the conversation in the room between the provider and other team members for that matter, and the patient, puts it into a note that just needs to be validated and stored. That is in the process, I know, of being trialed at Kaiser, at UCSF, at Davis. It's a tremendous opportunity. Now, I do have a little concern because many years ago, we were all told that the electronic health record was going to make our lives so much easier, and look where we are today. So I have a healthy amount of skepticism for this, but I think there is an opportunity there. Now, at CSFG, that is a year away. All of our colleagues in the private sector are trialing it now and putting it into place now. Why is it a year away? Well, we're still going live with Epic. Now, that's a good thing, right? Because we're going live in behavioral health, which is, very, very unusually on electronic health records, and it will provide us a lot of information that we need, especially for the population we take care of. But we can't do that and ambient notes at the same time because we have limited resources. So this is a great example of where, we're all in. We want to take advantage of all of the things that AI has to offer in clinical care, in provider and staff satisfaction, in the revenue cycle. I mean, there are a million applications that can make our lives better, but we can only do it when we have the resources, the time, and the expertise. And that is always less. Almost always. There are some things we can do better in, but it's less. And it's so in some ways our ability to take advantage of these tools, it's just a microcosm of how we are in the larger healthcare system. We're less well resourced, and that is a problem for equity.
Can I add just a little to this? And that absolutely, I think it'll help us be a little bit more efficient with how we do our work. But I think it'll also help. There's a moment in time now where we can look at the electronic healthcare record not just for the purposes of billing, because really that's why it's created, right? It's like, how do you improve your billing so you get your value-based care, credits, et cetera. But it's how do you incorporate information so that the patient can look at their record and to be able to interpret and understand in culturally linguistically appropriate standards, right? In the language of their choice, at the educational level that they are, not just verbally from the provider, but in written language. And I think that we've really sort of failed in that as a system. We have standards, but we really don't incorporate them. We have, we checkbox, yes, we ask the patient, what's your preferred language? But what I hear many providers say is, okay, I'll just wing it. I'll just speak in Spanish and, with the little I know, et cetera. But I do believe that helping Epic, which has really become really the model EHR, so that it's not just billing, but it is really how does it help empower the patient, and how does it help empower the physician so that the patient understands, the provider knows that the patient truly understands their, their consent or their management, and et cetera.
Thank you. Okay, before we hand over to questions from our colleagues and audience here, I just want to pull the thread a little bit on Susan's last point. I'm curious on thoughts from all of you on what it would take to really get to an equitable implementation across our safety net institutions. And I think we heard this from Secretary Ghaly as well, to make sure that we are not leaving the safety net behind. We're not focused this opportunity on the wealthiest communities. And so one or two thoughts on what would be helpful from policymakers or from others to help you get there.
I mean, we have to start with the basics. Is everybody on an electronic health record? You can't use AI unless you're on an electronic health record and you're utilizing it to its full capacity. That's the basics. And we know electronic health records are expensive. Epic is very expensive. They don't give the safety net a break, typically. So I think we have to start there.
I would just say maybe Epic should give all the safety nets a break, right? And right, I mean that, one of the great things about policy is they can make it possible for discounted prices to the public good, right, based on being allowed to do business in the state and things like that, right? So I think there are policy initiatives that might help that. And to make sure that equity occurs, and I actually don't know if we have we're sort of a county hospital too, because we're a level 1 trauma center, and we've been there for 150 years too, and there's no other trauma center for 33 of the counties, right? But we're a little better resourced, right? And so the question is, how do we share, right? How do we create partners, right? And that is something, UCSF is your partner, right? But how do they, if you will, get some degree of credit, right, for reaching out and doing all the stuff they're already doing, and then say, we want you to bring along Zuckerberg, to the same level? How does the state or the county support that? Because it's infinitely cheaper to extend the expertise than it is to build all that expertise in a redundant fashion. And so we need some sort of cooperative or collaborative. And it could be across, even, let's say, Sacramento has 4 different health systems, right? There's Dignity, there's Kaiser, there's Sutter, there's us. We've all got our own IT departments, right? I mean, why? Why aren't we say, okay, maybe we can have some joint assets that help get this done, and that's more of a collaborative with some input from the county? Because trying to get money for the FQHCs and other things that would benefit from this, and they're rebuilding it all from scratch. I mean, we're trying to help in our own way, but I think some policy initiatives that made it sense and allowed those collaboratives to support our safety nets would go a long way.
No question, resources are incredibly valuable in terms of directing resources to where it's needed, especially the safety net. I do think, though, that policymakers, and certainly at the government level and at every level, should have also has the responsibility of making sure that there is true structured collaboration, right, at every single level. And as I mentioned, representation, not just in the design of the data, but also the interpretation, and then also sort of how we use it. And so in many respects, I think policy are really part of our safety net right now, as we've entered this world of transforming healthcare with AI, using these new rules and regulations, but looking at it a little differently than just regulating technology. I mean, we have many companies that say, well, we really don't need a lot of regulation. In many respects, I know with the EU, who has been really dealing with this for much longer than the US has, they've also agreed it's not so much the painstaking, detailed regulation that you need, because some of that, whatever they regulate, whatever they approve, is going to change, right? In terms of how it's utilized and the data that's utilized. But it really is about how do we have the guardrails on making sure that we have those common values and incorporating those. If we're saying true collaboration, it's like, what does that mean? and at every level.
Okay, I've got a big stack of questions from our Zoom audience. I also want to give an opportunity for our audience here to ask questions, and I've been reminded to remind folks in the room that you have a blue form in your folder is an opportunity to give us feedback, which we do value. We look at all of these. They help inform what kinds of briefings we do and how we do them. So please, would be grateful if you could fill that out. For folks on the Zoom, I think that pops up at the end of the Zoom. So while my colleagues start handing mics around, maybe I'll get us started with one of this giant stack of questions. I've got a couple here that I think are related, so I'm gonna kind of wind them together around. Secretary Ghaly mentioned the opportunity for language access and translation services, and we've also seen both a lot of interest and I think a lot of fear around making sure that AI doesn't carry forward the racial biases that are already embedded in our system. And so I'd love to hear any thoughts from you both around how we can do that and how, given the complexity of language access and how different languages are, both what the opportunity is there and how we can mitigate risk.
I'd love to start on this one. I think first we need to make sure that we have the basic structures in place to deliver the interpretation and the translation that we want to deliver. So for example, do we have video interpreters? We know that video is really enhances the quality of interpretation that can be done during a visit. That takes resource to have that available for every interaction. It takes training, both in terms of having the application, having the hardware to deliver it, having the people trained to use it. And that's before you get to AI. AI, I'm sure, could be helpful here, but again, it has to do with the basic structure of, the resource we have to deliver the service, I think, is really important. And I know that doesn't exist perfectly in every setting.
I think there are new terms that are being developed, right, in terms of the use of data. As you mentioned, data is really based on what humans provide, right? And so there are certainly many flaws with much of our data, and we know many different biases. But algorithm fairness is something that I think is being incorporated into how do you sometimes do want to incorporate, increase the underrepresentation of certain communities if that data doesn't allow for incorporating it. So there really is a balance in terms of trying to decide how you incorporate algorithm fairness. And I think that's a whole different world on computational sort of integration of data. And I think that there are at many levels. So it's how do you incorporate that fairness at every single level?
I think this is a really important question, but because most disparities in care are actually more greatly driven by having English as a second or no language than it is actually by the sociodemographics. That is the inability to either understand the instructions, advocate for yourself, or express a full range of the symptoms that you may be experiencing, actually more important to health inequities perhaps than the community even in which people live. They just happen to overlap. And so the ability of AI to do real-time translation, where you're not depending on expensive interpreters, actually might lower the cost of care for everyone, especially in safety nets, and not only deliver the information in a native language, but allow the patient, because a lot of the interpretation is like one way, the doctor or the nurse telling the patient and then being interpreted. The ability to have a real two-way conversation, right, where, and you understand like slang terms and everything else. I mean, I can speak Spanish poorly, and if someone starts using slang, I'm lost, right? But an AI-generated interpretation tool would be incredibly valuable, immediately timely, and I think work to offset some of those disparities. So I think that's a possibility, but then you always have to worry. Okay, we mentioned this, right, about the perpetuation of biases, and I'm just going to tell a very short story, 1 minute, and which is we know that black and brown children get less pain medicine in emergency departments around the United States than white kids. That doesn't make any sense to me ever, and if you went up to any doctor or nurse in any ED in any hospital, they would look at you and say, you're nuts, because I treat every single human being the right way and the best way. But data doesn't really lie. And so if AI were making recommendations, this is really important to understand how AI works. It doesn't think. It just would like look back at all the treatment amounts that, a 7-year-old African-American boy might get, with a twisted ankle versus a 7-year-old white kid with a twisted ankle. AI would spit out and say, well, the optimal thing is a milligram of morphine for the African American and 1.3 milligrams for the white child, because that's the disparity in past delivery of care. So we have to guard against that, right, more than anything else, because we've done a bad job with eliminating implicit bias. And it's not AI actually that we have to worry about. It's not actually the computer programs. It's us. We perpetuate disparities because we don't act on that information, right? Even when AI is right. And so, and this isn't even true at UC Davis. We're struggling with this. So we've dropped our sepsis mortality, the overwhelming bloodborne infection rates, to way below the national average. We are doing great. And the algorithm is fine, but there's still about a 10% even though all people of all colors and all backgrounds have improved dramatically their survival rates, dramatically. There's still a little better survival rate for the Caucasian population. And it isn't because the AI algorithm isn't right. It's maybe there's still some implicit bias in the core of people delivering that care. And again, Fox called us the most woke medical school in the United States of America. It's not like we're not an incredibly liberal, adoptive place, fully embracing DEI. But even so, there are probably some implicit biases that exist. And so it's not only the AI, it's how are the AI recommendations being implemented that is probably the bigger risk still than that the computer is absolutely wrong.
I so appreciate that reminder that it is not the computers, it is us as well. That is very resonant for me. Are there any questions from the room that we should take? I've got a few up here. I have colleagues. I've got a ton. I've got colleagues with some roving mics.
You want to hold it? Okay, great. Hi, Johanna Liu from San Francisco Community Clinic Consortium. Very much kudos to the safety net hospital systems out there. And so representing community clinics, I think, you mentioned, Susan, that you're like a year away, maybe. We're like, I don't know, I think whatever plus more than that. I was at a convening recently where a community clinic piloted AI software for their note dictation, right? Not just dictation, but it would write the note during the visit. And I asked them, oh, okay, this sounds great. I said, did it work? Did you have high quality notes? The doctors had to read it afterwards. They said, yes, this worked great. So I said, okay, so are you going to continue doing this? And they said, no, we can't afford it. And I said, well, why not? Or why isn't that worth it for you? They're like, well, you don't get more patient time out of it, right? You don't get more revenue, you don't get more visits, the doc still spends the same amount of time. With the patients, it decreases the pajama time that was talked about earlier, right? So I don't know if there's some sort of startup funding or like some kind of focus on the conversation. We want the safety net hospitals to be doing great, amazing, but we also want out in the community health centers to make sure that we're also doing amazing. We don't want our docs leaving us for greener pastures or something that have less pajama time, right? So anything that we could do or any thoughts from you all, like how could we partner, or are there other policies at the state level that could support that?
Thoughts on partnership with your local clinic partners?
Well, we are in partnership with the San Francisco Community Clinic Consortium. We provide all of the medical and surgical specialty services there, so deeply grateful for your care and partnership. I just want to say, maybe this is obvious to everybody, but these differences, disparities in wealth are just a microcosm of a bigger issue. So for example, I was looking at wait times for total joint replacements for patients, my patients, your patients, right? Because it's all the same. It's more than a year that our patients have to wait, right? And when we look at our colleagues at UCSF Health, 8 to 12 weeks.
Wow.
And that's just one surgery or two. So it's a bigger issue. Not to make this more complicated, because it is very complicated. We can direct resources for AI in the safety net, clinics, hospitals. And we need to understand that these disparities go well beyond how we're resourced for IT.
Healthcare is complicated, so I think
That's why we
reminding us
love
that
it.
it's complicated is reasonable.
And we think about California, I think we have a leadership that supports the safety net to the extent that they can, right? When we look at other states and certainly other countries, I mean, clearly an incredible divide in terms of that access to care. And so it is a larger complex issue, but it's collectively, it's having that voice, that joint voice to say our policies need to make sure that they're incorporating those type of resources and access to safety net.
Can I take this one up here?
Good morning, sir. Yesterday you posted a LinkedIn post about patient expectations. And you wrote about that people expect the healthcare to be in the similar lines as the food delivery app, and they expect Apple Watch and Fitbit, all data to be known to providers. Again, there is a huge amount of data, more than 10,000 what you collect in the patient remote monitoring. So where do you see the AI helping in UC Davis Academic Hospital, as well as going down to your social application? Maybe you are running some safety net hospitals, or maybe I'm running some.
Right. No, I mean, that's a great question. First of all, 67. Oh, I'll just summarize it. Basically, there's a ton of data, not only from remote patient monitoring, but from all the other things that we do, right? From the number of steps that we take every day to how well we're sleeping. I mean, it's all here on my watch, right? My pulse oximeter, the oxygen in my blood, whether or not I have an arrhythmia in my heartbeat. I mean, there's a ton of data that's out there. And 2/3, at least, of Americans say they want the doctor and nurse to ask them about their stuff. And we never include that. And yet there's tons of information there, and even more coming, right? Because the speed of your speech, the lilt of your voice, the wavering in your step are all indicative of mental health or other types of issues that could be diagnosed if it were included in the medical record. AI can do that. We can't do that. There is not enough time in the world. I can barely interrogate my own watch, right? Let alone in that all day long. And I'm like, okay, how many steps did I mean, it's so easy, right, for a computer program, though, to come and gather all that information and say, hey, did you know that you're listening to the right side now? And, and then that helps you say, well, yeah, I guess I stubbed my toe the other day and it's still hurting me and I'm not paying attention to it. It's a very simple thing. There's a lot of more serious things that it might be. But who has the time to do all that? So AI is the answer to incorporating all these various data points that we collect on ourselves every single day.
Okay, I think I can take one more question. See Sergio's hand up.
Can you hear me? Okay.
Again.
Sergio Aguilar Gaxiola, UC Davis. The three of you, there is a common thread that I heard from the three of you and from Secretary Ghaly as well. And that is the key importance of building trust with the population, especially in the safety net. You use the word, the issues of trust of paramount importance. You mentioned, David, also progress is made at the speed of trust, something that has really... my question is the following. I didn't hear from any one of you the importance of trustworthiness, of being a trustworthy organization, especially for the safety net, because it is taking more on the responsibility for the long term to be listening actively to those that we serve, and that we serve with dignity and respect. So I would love to hear your thoughts about, how do you become a trustworthy organization, especially for the safety net?
That is such a good point. And it is, first of all, we have to talk and we have to ask, less talking, more asking. We have to understand what it is our patients need and want and expect from us. And so putting resources into that is really important. Having our own culture of safety making sure that anybody in the organization feels free to, point out where there might be a problem, so we can catch bad things before they happen. All of those things need to be invested in first before we're investing in AI. And one thing related to AI that I think is important that we haven't talked about is that before we even have regulations or before we make investments, we really have to have principles. We have to have guiding principles, things like beneficence, ensuring privacy, making sure that the patients are first in what we pursue. I know that these types of things exist. They exist at, in the international level, national, but each of our organizations, we need to develop these first. We need to have governing bodies and principles before we move forward with any of this work. I'm not sure all of us are doing that, but I would really put a plug in for that, because having guiding principles that really put the patient's beneficence, doing no harm, all of those things first are really important on this topic of trustworthiness. And we have to be constantly asking our patients, how are we doing for them?
And I agree. I think just to build on that, those core principles are so key, but that we all understand those core principles in the same way, right? Some of those principles are like human kindness, right, and human dignity, as well as transparency, accountability, et cetera. I think the way to do it is not just to make sure that those principles are highly regarded and utilized, so that there are incentives for those that use it and that follow those principles, and maybe penalties for those that do not, where there isn't accountability and reliability. But also, I think in that patient-physician interaction, that we ask open-ended questions, because I think that's how you build trust with individuals, right? As an institution, it is about setting up policies around principles, but in that day-to-day interaction, it is about sort of redoing our sort of changing how we interact with patients, so that it gives them that opportunity to speak and to feel comfortable in a trusting environment to speak.
Well, great question, Sergio, who is a leader in figuring out how do you become a trustworthy institution. And I will say that he's clearly always pushing me to do a better job. There's plenty to pick at. But that's great. So I think living your principles of community, living your principles, say what you're going to do and do what you're going and do what you've said, right? That builds that historical credibility and integrity, and always go back to the intent. And Susan and Carolina both, listening and asking the community that you're serving, what do they want? What do they find value in? Because, I'm really super excited about the stroke work. Okay, I'm like super excited because I just, it's just a fear of mine. I would hate to have a stroke and not have access to someone who could fix me, right? But that may not be the most important thing on the mind of the community. So trustworthiness is not putting your values in place of their values, but finding out what they value, because that is really critical, I think, to building that trustworthiness as an institution.
Okay, thank you. We are at time, so I'm going to wrap us up just very briefly by saying I think my two biggest takeaways, or three takeaways from the day. One, just a reminder of what an incredible opportunity this is to support our provider workforce, to create better outcomes for our patients, and to create the kind of healthcare system that I think we would like to see happen. And I'm reminded, again, of some of the risks. And so I guess my two takeaways are, one, if we want to make sure that we live into the promise, I'm hearing a lot about the technology needs to work, right? And it needs to work for us. And I'm also hearing probably even more than that it's not just the technology, it's what we do with it. It's how we deploy it, how we live into it, how we use it, what care we take, and how we're responsibly thinking through how do we make sure it reaches all of our communities equitably, how we see off some of the concerns around privacy, how we address some of the historic inequities that are baked into our system. So just a huge thank you from me to our panelists for sharing their wisdom and their experience with us. and to you all for joining us. Thank you.